Thank you. So we'll move on to the next presentation. I'd like to welcome Corinne. Dr. Corinne Hohl is a Canadian emergency physician, clinical researcher, and academic leader based in Vancouver. So she's going to be presenting on the Emergency Data ActionADE.
Hi, everybody. And I see that Johanna is here too. Johanna, feel free to unmute and participate in this. Johanna is one of my patient partners. We did not coordinate anything, but I'm just delighted to see that she's here and welcome everybody. I'll just share some slides. Um, just a quick sec. And if I can just get a confirmation from one of you that I am indeed sharing my slides, that would be helpful to me.
Yep, we can see it.
You guys see me? Okay, I'll just, if you don't mind, I'll stay on. Actually, let me just see. Okay, there we go.
Good.
Um, I just wanted to acknowledge that I'm attending this gathering from the unceded ancestral territories of the Coast Salish peoples, and I just wanted to express my gratitude for being able to be on these lands and live on these lands. And a lot of the work that is part of the ActionADE project is from across British Columbia, so touches on multiple territories. And I think everybody involved expresses their gratitude and is trying to be more mindful of that. Um, I just also wanted to acknowledge the varied funders of this work. Some of them were in kind only, but others actually really put in quite a bit of effort, including a lot of staff time, especially I'm thinking the Ministry of Health to make this work. And also, I co-led a lot of this work with an SFU professor who is now retired. And so I just wanted to express my gratitude to them. And then, of course, most importantly, I wanted to express my gratitude to Johanna, Laurel, Kevin, and Glenn. And really for me, I think, one of the most, when I read sort of some of the stimulus questions, really the overwhelming feeling for me that came up over and over again was this sentiment of gratitude. The roles that patient partners and patient engagement can play, I think, goes beyond certainly what I had imagined it. And when the question was asked, like, how did this matter or how did this start and what was the connection with SPOR and the BC support unit? I didn't necessarily come to it right away, but the most important thing that happened to our group was the introduction to this way of working. And so, Johanna, I think we met in 2017 when you bravely approached our team to because of your interest in adverse drug events. And so thank you to all of them. I would like to show you a video from Glenn because if you can just immerse yourself in that video, I think it illustrates what patient partners, I think one of the most important roles that they play. So I'm wondering if you guys can play this video and maybe I'll stop sharing. Okay. Did you want me to click on the video or Josh, are you able to make the video play?
Glenn Metcalf. I have a history of type 2 diabetes and high blood pressure, and I've been on medication for a number of years. I was admitted to the hospital the Friday just before Thanksgiving with unknown issues. Well, I didn't know, and nobody else did either. They had to struggle to keep me alive.
I vividly remember at about 6 a.m., I was working a shift at Vancouver General Hospital when I received an incredibly sick patient from the ambulance. He was sitting bolt upright on the stretcher. He was writhing in pain.
I really don't remember much of anything at that particular time. I don't remember arriving at the hospital.
I've never experienced anything like that before. The way things went so fast and the way the hospital staff didn't know what was happening. Somebody thought he was having a heart attack, somebody thought something else.
As we were preparing him to go to radiology, he actually stopped breathing. And fortunately, we were able to resuscitate him.
I think that's when it really hit that he might not make it. We basically started to pray.
His pH was 6.67. That's the lowest pH I've ever seen in a patient who's alive. And at that moment, it was very clear to me that this was likely related to one of the medications he is on. He was on one of the most commonly prescribed medications for diabetes called metformin, but in him, it was causing a very significant adverse event.
They had to start from scratch, go through all my records, find anything that may have been related to this.
What took a lot more time was to figure out that this was not the first time this patient had had such a terrible adverse event to a medication. In fact, he had already been admitted twice before to one of our hospitals with the exact same diagnosis. So this was his third adverse drug event, and he almost died from it.
I didn't know that Glenn had gone to a different hospital at another time, so why wasn't there any information on that? Like, why didn't somebody know? How do those types of things happen?
You know, the third time, much more serious. I can't even speak to how serious it was because I was almost dead. Over the years trying to keep my diabetes and blood pressure under control, I've seen some specialists and some brilliant doctors. I'm just not sure if there was kind of ongoing communication between everyone. So it's a collaboration between all of the levels of health, from your pharmacist to your family doctor to your specialist.
Patients who have adverse drug events, they frequently, unfortunately, get re-exposed to the same drug. We often have to adjust the dose. A lot of times we stop the drug and replace it with something that they have not had an adverse event to. But in order to be able to do that, everybody within that patient circle of care needs to know about that adverse drug event. For me as a care provider, it feels like we're not connecting the dots correctly.
When you go to a doctor, they can generally look up all your medications. What they don't know necessarily is that you've had problems with certain drugs. And that's where a program like ActionADE could really step in to make sure that the specialists and your regular general practitioner have the information, or forbid, the hospital staff have that information so they can act quickly on your past history.
This is a problem that can be solved with health information technology developments. It's not a simple problem to be solved, but it can be solved. And we've shown with ActionADE that we can solve it. This type of solution would make our health system so much safer, and I absolutely believe we can get there.
Thank you for playing Glenn's video, and I'll just share again. So it was just important for me to share with you Glenn's video, which I shared with his consent. Glenn continues to be a patient partner, and we're extremely grateful for his willingness to share his story. So he was not only my patient, but then he did come on board, and along with Johanna and Laurel and Kevin has really tried to help us move this system forward. Does anybody want to, I'm very comfortable if people just want to unmute and ask questions along this journey. And if not, I'll just share with you some of the key lessons I think that I have certainly learned. So excuse me, somebody just is knocking on my door and I have no idea who. I just have to, my apologies. Sorry about that. So one of the things that has struck me over and over again as I've done this work is the fact that as researchers, sometimes we struggle to engage with decision makers. And if it were up to me, a system like ActionADE would have been implemented years ago. It would have been implemented in 2020, when we first identified this problem, when we identified that across our healthcare system, there are probably upwards of 100,000 emergency department visits every year across the province because of I'm so sorry. Somebody's trying to deliver a package and I didn't expect that. And so my dog is shh. Um, and so if you can just think about it, even though we've described this problem, unfortunately, we can't make the decision. We can't make the decision to actually implement this. And so one of the lessons that I've learned as a scientist is I can engage with decision makers and I can talk to decision makers, but stories like Glenn's story is a very, very unique story and really can help actually facilitate that conversation or open the doors. It's also, I think, really important for us to consider that when we do have lived experiences on those issues, those medical issues that I have personally lived experiences on, I I have a positionality around the issue that I experience. As a scientist, I disclose that conflict of interest of what I believe a solution to be, and it positions me in a different way than it does to be a patient with lived experience. And so that's just one idea for reflection and really generating that evidence that allows decision makers to hopefully understand why they are making a certain decision because they can't implement all of our ideas. They have to choose carefully what they're going to invest in and what they're not going to invest in, I think is really helpful. Another lesson that I learned was, sort of a personal lesson for me in terms of advocacy versus science. And in many ways, when we find these problems, and this is a problem that I didn't find through personal experience, this was a problem that I found through science, through my experience in treating patients who came to the emergency departments with these adverse drug events. Um, uh, it's I had to continuously remind myself that my position as a scientist was about learning. It couldn't be a commitment to confirming what I thought the solution was, but it had to be a commitment to ongoing learning. And so that's been another really interesting thing to think about. And I think patients have this real power and also this real ability to take on an advocacy position that is much more difficult to take on as a scientist. So it leads to some interesting thoughts about what is science and what is advocacy and where does that overlap sort of exist. And then the other thing that this kind of presentation stimulated me to think about is Johanna, I'll bring you back to, since you're here, I hope it's okay for me to state this. I remember when you first approached us and said, gosh, could we get patient-reported adverse events? So similar to what she was, sort of reporting. And we just couldn't get that through ministry because we actually hadn't generated the science about the validation of these events, about overflagging that were concerning to health system decision makers. And so it's really important for us, I think, to sort of sort out some of these ideas in terms of their novelty, in terms of how they can enrich some of the science, but also more recently, in a different research program that I lead, some of the ideas we're going to have to wait and we're not going to be able to probably act on them right away because they might not allow us to deliver on some of our primary funded mandates. So these are just thoughts that I had in preparing this conversation. And I'll just stop there and open it up for further thoughts and reflections. And Johanna, feel free to jump in. Thanks.
Thank you so much, Corinne. That was wonderful. Are there any questions? I'll take a look at the chat here and see if anything's come up. I did have a question about the role of pharmacists.
Yeah.
Because I've done some work with type 2 diabetes as well. And one of the projects I was working on was with elderly patients. And we encourage them to work closely, build a relationship with their pharmacists because they're normally they're the ones who are dispensing and they have their history that's available to them. Is that something that you work with?
Yeah,
Yeah.
absolutely.
Yeah.
So most of the adverse drug events that are reported in ActionADE, about 95% are actually reported by pharmacists.
Mm.
Um,
Yeah.
I think it's really important to distinguish between medication reconciliation, which is simply a reconciliation of the medications in a new setting, but not necessarily a review to understand whether or not medications are being effective and whether or not they're causing adverse events for that patient. So yes, absolutely. And a lot of the people who funded our work, we work closely with the College of Pharmacists in British Columbia. They actually helped fund some of this development.
Thank you. Any questions from anyone else?
Can I ask
Joanne?
a question?
Oh,
Oh, go ahead.
Joanna came off mute.
Yeah, thank you very much. I'm sorry, I'm having technical difficulties, so I'm having to view this on my phone today, and I don't want to turn the video on as well because I'll lose power, I think. Um, it's been it's been incredibly interesting and inspiring to work with Corinne on this project. It's also incredibly frustrating that this system that could be saving actually so many people from both suffering and dying of adverse drug events has not been implemented in this province, and it could be. There seems to be even less possibility of that with the latest budget. Um, a lot of the interactivity of our systems that we hoped would go forward, I think, are on hold because of budget constraints. So I think that one of the things that can be helpful is people being able to access a clinical pharmacist through their primary care networks. And there are many, many of them throughout the province, and quite a few of them, probably the majority of them, have a clinical pharmacist. And there you can go and have an interview and have your medications, your whole medication list reviewed for interactions or problems with dosage. So I just wanted to mention that so that listeners can understand that there is at least some help available. And I think the other thing I wanted to suggest is that there's just not enough connectivity between primary care doctors and emerge doctors. I'm on a different project that's looking at something called hyperkalemia, which is when your potassium is too high, which is a very dangerous condition. And the fact that we're seeing that over and over in emerge, and yet primary care physicians are being advised by the guidelines that the best medications to treat cardio problems are the ones that actually cause high potassium. So there's some kind of breakdown in information between primary care and emerge, and I'd like to see that somehow alleviated. And I wonder if Corinne has got any ideas about that. Thanks.
Johanna, I don't know that I have solutions aside from implementing a system as we developed. It has been extremely frustrating, as you know, for me to work so far to develop this system, implement this system, and then kind of see it stalled. But I think there's a common thread to what you're saying in the presentation before. And I think the common thread is that every patient is really quite unique. And you know how talking in terms of dosing of medications, for example, some of my work also touches on the toxic drug crisis and trying to understand, well, what is the evidence? At what dosing should we be giving hydromorphone, PRN to keep patients out of withdrawal? At what dosing, you mentioned long-term care. So the issue is that these questions are really complex. There are not simple solutions to just say this is the dosing recommendation and this is the medication. Our guidelines are guidelines, and as physicians, one of the unintended effects of this guideline-based care is that we put everybody on the same drugs, and then when evidence comes out that, for example, atypical antipsychotics are harmful, which they are, or associated with harm in long-term care, and we try to remove them. But I think it speaks to the complexity of the decisions that care providers need to make on a day-to-day basis, because a lot of people who are exposed to the drugs that can cause hyperkalemia in some people will actually do fine on those drugs. Same thing with, when we're trying to keep patients out of withdrawal who come in, who desperately, want to stay, want to see addiction medicine. We're just trying to get them and keep them out of withdrawal until we can get an addictions doctor there. That dosing tolerance is going to be patient driven. And so I think the whole common theme is that, again, back to this thought about what is advocacy, what is science. I think it behooves us all to advocate for a system that allows us to really produce the evidence that we should be making decisions with. But I think that a lot of our work, there is often no one size fits all or one dose fits all. And I think I am just appreciating the complexity of all of these decisions. And I think our decision makers, I think they're very good people, but I think sometimes the information is overwhelming. Like, do you prioritize ActionADE, or do you prioritize system B, or do you prioritize intervention X? And so I believe as a community, what we need to really ask ourselves is, are we here to advocate, or are we here to ensure that the science is well informed with patient experiences and stories that can help move the science further so we can really understand these things in a more nuanced way? I might not have answered your question at all, but that's what your question triggered in me in terms of thoughts, Joanna.
Yeah, thanks, Corinne. I understand about it being a very individualized decision and not, one dose or one medicine fits all. And that's why I wanted to make that remark about the clinical pharmacists that are available in the primary care networks, because they can look at you individually and see, if there's something there that maybe needs to be adjusted or fixed.
Yeah. And as you
And
know, oh, sorry.
doctors don't, primary care doctors just don't have time to do that, nor do they necessarily have the expertise, with looking at drug interactions. Yeah, so that's kind of what I was getting at. Thanks.
Thank you, Joanna. We have Shay and then Denise.
Again, in assisted living, I will go to my to Lawrence, my nurse practitioner, and if I'm on a medication, he will increase the medication, which is sent through, I believe, on his computer or faxed, one or the other. It's sent to the pharmacy, and then they keep all of my medications in a locked drawer. Comes in a bubble pack in a locked drawer, and then it's given to me by the CareAide. So it never actually touches my hands. I never pick it up, go get it, or do anything myself. It goes from the doctor to the pharmacy to the drawer to the CareAide to me. So what happens with my pharmacy is that, and also there aren't that many pharmacies that deliver. Okay, now this pharmacy that I have delivers, and I want to find another one. But anyway, they will change my medication. My doctor, Lawrence, will give them the change in my medication, but it won't change for 2 or 3 weeks. And the nurse here will call and say, why hasn't it changed? And they'll suddenly go, oh, I guess they are supposed to, change it. Yeah, we'll do that. And the whole thing is just so unorganized, unfocused. And then when I wrote a letter complaining to the head guy and the head honchos, because this happens repeatedly over and over and over again, And then the head pharmacist called me and blamed me that it was my fault, essentially, that they were not getting done. My prescriptions were not getting refilled in a timely fashion because these poor little pharmacists were so busy, refilling all our bubble packs that it's up to me now to phone them to tell them when I'm getting my prescription changed. And then they'll be able to do it more efficiently. So I'm not sure how any of that can be addressed in terms of where the holes need to be filled. I mean, is that something that goes to the college of the pharmaceutical college? And can it be addressed that way? Or, I mean, because that's a pretty big hole. I mean, when I wrote my letter to them, I said, if you don't smarten up, somebody's going to die. We're old people. You can't screw around with our medications like that. And especially when you're dealing with pain medication, that's tricky stuff.
Yeah.
So anyway, that's my question. How do you fill in the gaps there? I mean, technically the only control I had was to go to the doctor in the first place and have the discussion about how to change my medication. From there on, it was in somebody else's hands. So I don't
I'm
know.
so sorry you had that experience, Shay.
I'm sorry,
Yeah.
if that makes sense to you.
Yeah. No, thank you for sharing that. It's I think there's a lot of gaps in the system that our wonderful people like Sharon and Christopher and Corinne now are working to fill. And that's I'm so sorry that was your experience, and I'm hoping that it's improved. And from your stories about your NP, and I think it's getting a bit better. Yeah. Denise?
Hi. So, yeah, thank you. I was quite stunned by your presentation, and I might have, in that state of being stunned, I might have missed what I'm about to ask you about. But I live in Alberta, and so a few years back, the government invested a huge amount of money in implementing EPIC across all of our acute care sites and some rehab sites and some, but not all, primary care settings. And so with that knowledge in mind, like, I'm struck by like the experience of your patient, who had three of these adverse drug experiences, because I guess my curiosity is, in this era where there are systems to join up communication between specialists, the ED and a primary care physician, however imperfect they might be, why would somebody who's had multiple adverse experiences with the same drug, like, is it just a matter of what you were saying, the complexity of decision making around changing amount, or is it just some communication gets lost and the medication gets prescribed again, or was the AD not recognized the first two times, or it's just
it's a perfect question, and I think I if it's okay for me to respond, I think I completely understand your question. This has been the bane of my existence.
Okay.
With the ADE work, not with the work that I do with substance use, but I think it absolutely applies to substance use as well, because anyways. But so I've just put in the Canadian Interoperability Roadmap, which basically describes some of this problem. So Alberta, in this instance, is way ahead of BC. BC did not have the foresight to implement one provincial EMR across all of our acute care systems. And we're paying for it now. And so what happens is British Columbia currently has 5 different electronic medical records, 2 different brands, but 5 different instances or versions of a electronic medical record implemented across its hospitals. And so there are places And this is not unique to British Columbia. I will tell you that Ontario and Quebec have done similar things, where you go inside one hospital and there's a big fancy electronic medical record implemented, but when you cross the street and you enter into a different hospital, they have a different medical record and they cannot communicate. And this has to do with a concept called interoperability. We don't just need electronic systems that are silos of information. We need the information to follow Glenn and you, Denise, and me, and Jessica, and everybody else across medical systems, and not just within hospitals, but across into the community pharmacy, into the hospital. So fundamentally, what we identified is the clinical manifestation, these repeat adverse drug events, and they kill people sometimes. I have seen people almost die from these, where this lack of information transmission, this because of lack of systems ability to exchange this information, it's because the information does not get transmitted across the system. And this exists in British Columbia, in Alberta. So Alberta has Epic in the hospital system, but your family physicians will not have Epic because they're designed differently. And so what ActionADE, it's trying to figure out what is the minimum required data, because as an emerge doc, I can't pay attention for more than 30 seconds. We all have ADHD, right? But we only need a small amount of precise information to actually make the right decision. But we need that on a patient level. We need to know whether something is causing hyperkalemia or not in you, not in everybody, but in you to make the right prescribing decision. So we started by figuring out what that minimum data set is, and then putting that minimum data set, how to get it out of one system, and then put it into another system. So effectively, think of ActionADE as this way to understand what information is needed, how to put it into a system, and how to transmit it. Sorry, we're probably out of time, but that's effectively the problem, the system problem that we're trying to solve that is not yet resolved in Alberta, and it's not yet resolved in the other provinces. It's a real issue.
Okay. All right. Thank
Sorry
you.
to shock you.
No, it's good to know.
And this, I'll tell you that this recurred for Glenn within the same hospital system, and it has to do with the documentation standards, that our EMRs were not designed with this problem in mind. So, anyways, it's a long story, but you have to be really careful about what documentation is needed, in what format, when is the information presented, and where does the information go. And maybe I'll stop there, but
No, thank
All
you
right.
for the
Okay.
great question,
Thank you.
Denise, and thank you, Corinne. And thanks to everybody who attended. Both presentations really highlighted the importance of lived experience in catalyzing change, especially in health systems here in BC. And the connection between patients and providers is so important. And I just want to say a big thank you to Corinne and to Sharon and Christopher for taking the time today to speak to us about the work that you're doing, and for everyone who's in attendance. If you have any additional questions, please feel free to reach out to presenters or to the conference planners, and we can facilitate that as well. Okay, take care. Have a wonderful day.